Great. So this is our first presentation, the Amiable Avengers. And they are going to talk about their experience in our interprofessional team immersion. Thank you, Sarah, Rose, and Jessica. And thank you to our faculty who supported them, Bree Fortin, Nancy Jo Ross, and Pat Kokomo. So let's get started.
Hello, everyone. Today, we are going to be talking about managing pediatric asthma through interprofessional telehealth collaboration, where effective collaboration in an interprofessional healthcare team is possible, even in telehealth. We participated in the Interprofessional Telehealth Immersion Program, and we are Team 2, the Amiable Avengers.
So for the presenters here today, we have myself, Sarah Shaw, a nursing student, Jessica Jawhar, a medical osteopathic student, Rose St. Paul, a dietetic student, and the other team members from this experience included Libby Bresniak, a dental student, Brianna Burke, a pharmacy student, Rebecca Corbett, an occupational therapy student, Hilda Everson, a physical therapy student, Carrie Grace, a dental hygiene student, and Lloyd Seeley, a medical allopathic student.
The IPTI Challenge features students from various health disciplines, and the IPTI simulation involved understanding professional roles and responsibilities, communicating openly and respectfully, establishing common goals, and respecting diversity, sharing knowledge and expertise, and developing a patient-centered care plan through interprofessional collaboration.
For this simulation, our client was a 6-year-old patient named Charlotte who was diagnosed with allergen-induced asthma at the age of 4. Currently, her primary symptoms consist of a persistent cough, becoming easily winded and fatigued. Her parents, Simone and Daniel Soto, were distressed about her condition, so they turned to their community health team for answers.
Team collaboration. Through teamwork, high-quality care was provided for Mr. and Mrs. Soto. Additionally, actionable and sustainable goals were developed to address the overall health and well-being of their 6-year-old suffering from asthma. And today, a few students from the interprofessional group will speak about their experience. Here's a quote from one of our facilitators, Professor Brianna Fortin, Nutrition. Team 2 worked so well together, and by the cohesiveness of the care they provided with Mr. and Mrs. Soto, it was clear that they trusted each other to provide the input that was needed for this case. Empathy was also a strong suit of this group from all professions.
Thank you, everyone, for your time, and we are opening the floor for questions. Thank you.
Great. That was great. So who would like to begin by asking any questions? Well, I will begin. Because over the last several years, telehealth has become really something that all of us as health providers need to know how to work with. And because you did this case study with the family, Mr. and Mrs. Soto, I'm really curious about your experience of telecollaboration, what you really learned in the experience of working together using a telehealth modality.
I don't mind starting. Hi, everyone. I'm Jessica, and I'm from COM, so an osteopathic medical student. I think that's a really important question, and I think we all learned a lot overall. I think the biggest thing is through telehealth, it's very hard to communicate well just because you're not there. It's hard to see the nonverbal cues that we learn about. But through that, it's a good experience. Like, this was a great experience to learn about that for the future, for our future patients. And I think it was also difficult not being able to speak with the patient who is a pediatric patient, and being able to like open that trust from the beginning, just for not being in person, because there was a lot of things going on in the family, and it took a lot of time to establish that trust, because I think through telehealth there's a disconnect, like a human personable feeling. But with that said, because of like us also working behind the scenes, we were constantly communicating as like an interprofessional group, always thinking who's able to like contribute their skills in this part of the case, who thinks they're confident in like being able to tackle this. And like through Rose, we were all able to like also learn motivational interviewing. And so that's where we had to adapt different skills, especially for telehealth. and just like approaching the patient in like a more like applicable way. So I hope that kind of helped.
I'd also like to add that just through this whole experience, we were able to see that even though it's, relying on telecommunication to really collaborate with each other, it can be done. And it's all about respect. It's all about really learning the core of what what everyone does on the team, and really playing on those strengths to service the patient, well, the whole family, because if the parents aren't 100%, or if they're not healthy, or if they have these mounting issues that they have to deal with, as we saw, they moved to a new neighborhood, they were having financial issues, like we really had to approach it in a holistic way. And I think that all of us understood that, and I think that that's what really strengthened our collaboration efforts to really provide the care that the family needed.
I have a question
agree.
for the group. Oh, go ahead, Sarah.
No, that's okay. No, I was just wanted to mention too, like, I definitely agree with Jessica and Rose's points. Like, yes, 100% sign off on that. But I think one of the big challenges with telehealth is just letting the patient know, like, even though we're so remote from each other, like, we're still here for you. And I really had that at the forefront of my mind through this whole experience, especially from the perspective of nursing. So to keep that going, I even started our introduction with our family of, just saying, like, what are you hoping to gain from this? Just to really, like, let them know we are here for you. We want to help you succeed. And yeah, so I think that's really important too, because a lot of that can get lost in communication, especially on telehealth.
So this one is supporting health with harm reduction, Cumberland County Jail Wellness Bags. And the team includes Lauren, Riley, Sarah, and Caitlin from COM, and Sarah May Rose from Pharmacy, and Caitlin from Occupational Therapy. And thank you to Chris Bates Withers, Chris Hall, and Christina Stewart for being facilitators and mentors for this group. Take it away.
Hello, today we're presenting our project titled Supporting Health with Harm Reduction, Cumberland County Jail, or CCJ Wellness Bags. The purpose of this project is to support the recovery, reentry, and overall safety of residents departing the CCJ, and offer supportive resources to the correctional officers at CCJ to reduce stress and increase overall well-being based on the high prevalence of overdoses from individuals reentering the community. We're an interprofessional team of students and faculty from multiple programs at UNE.
We held a focus group with CCJ residents in February. Their feedback was vital to the implementation of this project and helped us create a list of supplies to include in the harm reduction kits. We collaborated with community organizations that provided donations, including wound care materials, bus passes, water bottles, and clothing vouchers. We partnered with the College of Osteopathic Medicine Addiction Medicine Club to create wound care kits and write handwritten cards to residents that were included in the harm reduction kits. We held a wellness event for correctional officers in March and led a harm reduction kit packing event in April at CCJ.
For our correctional officer wellness event, our team traveled to CCJ, where we handed out wellness bags to the correctional officers to provide support and improve their overall well-being. The wound care and harm reduction kits will be distributed to residents of CCJ upon their release. Our team packed wound care supplies to treat wounds and prevent infectious disease. We specifically included these supplies to combat the rise in xylazine, a large animal tranquilizer that is now being mixed with substance supplies and is associated with severe, rapidly spreading wounds. It is our hope that these kits will reduce overdose fatalities and incidents, support recovery, and promote the overall well-being of those re-entering our community. Our team met with a focus group of 4 male residents who use substances or are in recovery. They provided feedback on items and resources that would specifically support them through their first 24 hours upon re-entry. We use this information to create a resource packet and include specific items in our kits. In total, we packed and distributed 96 wellness bags for correctional officers and 200 wound care and harm reduction kits that will be distributed to residents upon their release from CCJ.
During this project, we learned to work together as a team and brought different perspectives and approaches to harm reduction and ways to support this population. Our next steps, we would like to continue fostering relationships with CCJ and gain feedback on the kits, maintain and expand community partnerships, continue our efforts for student recruitment to maintain sustainability of the project and bring in more health profession programs, and apply for more grants to support creation of future kits.
This project was grant funded. We would like to thank the CCJ staff for their collaboration and community organizations for their donations. Thank you to the UNE faculty and staff who supported our team.
Fantastic. So, do we have questions for the group? I always start, and I have a real fondness for this group, but I'm going to let Mike Sheldon start.
Maybe I'll go ahead and start. My name's Mike Sheldon. I work in the provost office. And I guess I'm curious about one of your next step, because you mentioned expanding partnerships with other community members and the intervention, what you had worked on, there's this one-time thing and you want to sort of know the impact of that. What are your thoughts about that in terms of sort of ongoing support? And what are the other community partners that you'd want to connect with as it relates to, more ongoing support in this context?
I can start off. Hi, my name is Lauren. I feel like continuing to foster the relationships we've had with community organizations that we reached out to and who are really excited about supporting this project. So we had donations from Portland Metro, and as well as the transportation system in Biddeford, Saco, Orchard Beach. They donated bus passes, so continuing to foster that relationship. In a focus group with 4 residents, they had mentioned that the bus passes are super important to be able to get to where they need, since the jail is located on the outskirts of Portland, not right near the resources they need. We also, a new donation we had this year was from Goodwill for vouchers for clothing. So I think continuing that relationship and also building relationship with harm reduction organizations, maybe expanding to organizations like the Church of Safe Injection. We partnered with the Portland Needle Exchange, so they are the ones that really support us in creating the wound care supplies, just for overall first aid and with wounds for xylazine. So those are a few, but just any organization that we really feel like can help and would be willing to donate.
Hi, my name is Riley. I had a follow-up to Lauren's answer as well. She did mention that we have a relationship with Portland Needle Exchange, and actually in the resource packet that we give to residents leaving CCJ, there is a little card that we include with a map, and it lets them know how to get to the Portland Needle Exchange, and they will kind of supply anything that they need. And they also do some blood testing as well. I think they do HIV testing and some testing that they may need as well. So that's kind of more longitudinal care. We can send them to Portland Needle Exchange for any sort of issues that they may be having, and to get more wound care supplies if they need that as well.
Great, thank you. Other questions?
Shelley, can I ask a follow-up?
I think I'll let you, yes.
So for any of you who this was new to, I'm kind of curious if any of you had conflict, going into this, that, I don't know about this. There's been literature written and opinions on both sides of whether this, how this works. And if you were conflicted, how did you resolve that conflict?
Hi, my name's Kate. One thing that I was a little bit nervous about was the environment and like the support that they get in the jail as the residents, but that is shifting to be more supportive and to be more inclusive of the harm reduction kits that we're passing out. And so that was a positive impact that this had on me.
And just to quickly follow up, my name's Sarah Mayrose. I'm from pharmacy. I think the reason that we all got into this was because we knew that there is an issue and that there is something like with the environment and the some sort of like the hostility that can be there. We wanted to combat that. That was really the biggest thing that we were working towards. So I think that was the biggest reason that we got into this project.
So our third presentation is from FIT, public health problem-solving paradigm and interprofessional team training. And this is Mr. Pierre and type 2 diabetes. And our student team are Andrew, Ariana, Shell, and Kathrika. And our faculty mentors are Dr. Ling Sao and Kin Lee.
Hi, everyone. We are FIC Team 2. My name is Andrew, and I'm a second year at the College of Osteopathic Medicine.
My name is Ari, and I'm an undergraduate medical biology major.
My name is Chell, and I'm in the Masters of Public Health program.
I'm Kartika Singaravelu from College of Osteopathic Medicine. Moving on to our case, Mr. Pierre presents to the mobile frame farm worker outreach clinic of a local federally qualified health center to check his blood pressure and reported a prior diagnosis of hypertension for which he is not currently medicated. Upon examination, it is discovered that Mr. Pierre has uncontrolled type 2 diabetes with an elevated levels of A1C and PSA and also hypertension.
So moving on to our framework for some protective factors, we have that he does see the clinics in both Florida and Maine. He has access to a local food bank and has strong social connections with family and friends. He also displays consistency in attending these mobile health clinics, and he is not a tobacco, alcohol, or drug user, and he does have reliable transportation of his own car. For some risk factors, he often resides in a food desert, has unmet medical needs because of insurance status or language barriers, and has poor worker housing conditions. With this, he also has limited income, no medical insurance, and does not currently qualify for main care or SNAP because of existing benefits in Florida. And he also lives in close quarters when at the worker housing conditions and eats a highly processed poor diet and is often exposed to heat, UV radiation, and pesticides.
So we identified 5 different categories of interventions for Mr. Pierre, starting with medication counseling and side effect management. The main part of medication adjustment was switching to Januvia, which is a different medication for diabetes that has fewer side effects, which will help with compliance. We also recommend Merck Helps, which helps with cost of Januvia, and a PO box and other sites for cheaper medications. We also recommended applying for residency in Maine because Mr. Pierre would then be eligible for Maine care. Also connecting Mr. Pierre with a patient navigator who can assist him with transferring residency and benefits from Florida to Maine.
We also identified some opportunities for telehealth use, which could improve his adherence to his medication and improve his continuity of care, regardless of where he resides geographically during the year, and allow communication between his providers, as well as some opportunities for patient advocacy, considering the inadequate housing which he finds himself in as a migrant farm worker on many of these farms. And so bringing in organizations such as Farm Worker Justice and the Department of Labor, as well as advocating for better interpretation access, which is a legal requirement for many of these healthcare centers. Thank you so much for attending our presentation.
Congratulations, that was great. So do we have any questions? Well, I have a bunch of questions. So I can start. I'm really interested in, there's a complicated case, and I'm really curious what you learned from each other in working this case together. And the second question, just in case I don't get it in, is what you learned about this population, which isn't spoken about very much in your curriculum. So I'll throw those 2 questions out to the team, and whoever wants to respond, that would be great.
I can start. I feel like one of my favorite parts about working in an interprofessional team of this nature was just seeing my own blind spots. I have, a public health background, and so there were, clinical things or just different things that were coming in from different members of the team that are just completely, not in my wheelhouse. And it was really exciting to be able to interact in a team setting where, people have different experiences, different educational and different personal experiences that they're able to bring to the table to contribute in that way.
Thank you. That was great. Other members? Andrew?
Yeah, so kind of going off what you and Shell just said, this was a very difficult and unique case. And so it definitely highlighted the importance of needing a multidisciplinary team to kind of approach it from all different angles. And so that was kind of my biggest takeaway, is that I realized like every member of the group had different strengths and was able to, as Chell said, like see or like help contribute to blind spots that our disciplines kind of teach us or, narrow our focus into, but then other members could contribute in different ways. And so I feel like with a case like this, it really, again, highlights how important it is to work together in teams and, improve the overall patient outcome by approaching it in many different aspects. So that's great.
Thank you.
I think I'll touch a little bit on also the you've mentioned the population. It's a very invisible population, particularly here in Maine. It's something that I personally have a lot of experience with, and I feel like that was one of the strengths that I brought to this project, was just the knowledge of that population. But again, like Andrew was saying, everybody kind of fills in with their own expertise and contributions. But I think that one of my main goals in presenting this as a case for us to discuss was to shed light on this population, because it is such an invisible and not widely discussed population in the medical field.
Well, Jill, we appreciate that, highlighting a really important population for health providers to be thinking about and working with. So I'm thrilled you brought your knowledge into this discussion. Thank you. All right, I think we're coming to our final presentation, and this is also from our FIT group. And this is looking at tuberculosis, another topic we don't discuss very much, and the public health paradigm. And this is Evan, Emily, Ava, and Cindy from a physician assistant, two from public health, one in the graduate program, one in the undergraduate, and from osteopathic medicine. And again, thank you, Dr. Sal.
Good evening. This is Team 4 with the Public Health Problem Solving and Interprofessional teams, and we're providing a theoretical case study of acute tuberculosis in Portland, Maine. Our patient is DW, is a 28-year-old social worker who works with unhoused populations, and he's presenting with acute tuberculosis after a 4-week history of persistent cough, chills, night sweats, fatigue, and shortness of breath with activity. He's also lost 10 pounds unintentionally over the last month. He thinks that the high stress of his work is what is causing these symptoms. Nothing makes it better. He denies chest pain. He doesn't own a thermometer, so he doesn't actually know if he has had a fever. His past medical history is exercise-induced asthma, chickenpox, bipolar disorder, and HSV. He takes Truvada for PrEP against as a HIV prophylaxis. He has a albuterol inhaler and takes valcyclovir for HSV flare-ups. He has also had a tonsillectomy in the past and no known drug allergies. Social determinants of health. He lives alone in a nice 1-bedroom apartment in a safe area of Portland. He is economically stable. He doesn't have to worry about money for rent and food. For his education and employment, he has a master's degree in social work, and he's currently employed by Maine Health. He has a close social support system. He plays on an LGBTQ volleyball team, has a good relationship with his immediate family, and has several close friends in the area. He identifies as a non-Hispanic white male. These social determinants of health are further subdivided into individual, family, friends, community, and environment. Starting in the smallest circle, individual, we have his age, his education, his past medical history. Under family and friends, he doesn't own a pet. He's single. He doesn't have a romantic relationship. He has a close relationship with his immediate family. Under community, the friends he has that he meets up at bars, the kickball team that he's in, his friends and coworkers. Under environment, we have Portland has generally good air quality. It's accessible with a car to grocery stores, and he lives by himself in a neighborhood that has good outdoor space for recreation. So for some of our interventions, first and foremost, medical treatment. He's going to need to be treated with a combination of antibacterial medications, and he's going to need to isolate for 7 to 30 days until the infection is cleared from his sputum. Because he's going to be isolated for so long, we want to make sure that he has telehealth options. And given his history of bipolar disorder, we think it's important that he looks at some apps that focus on stressor therapy or telehealth therapy options. Given his lapse with PrEP recently, we think it would be a good idea for him to talk to his primary care provider about Apretude, which is an injectable form of PrEP, and to maybe look at transferring to Franny Peabody or Planned Parenthood for treatment. The state's going to end up providing him case management as well as food assistance and direct observed therapy So a nurse will come out and make sure that he's actually taking his medications. As far as his work as a social worker, we think advocacy would be a good idea, fighting for more social workers at Maine Health, as well as getting involved in education of new social workers. We also think that since he has a work-related exposure, that he could apply for workers' compensation. If he still is running into some financial problems, GoFundMe would be an option to crowdsource, and then using things like Uber Eats or DoorDash or Instacart for groceries. Thank you very much.
I want to applaud too. That was great. I was really interested in this case because I don't know what the pervasiveness of tuberculosis is in Maine. So I was really curious about this case and what you learned about it as a team. That's my question.
I can start. This is Emily. I am in the public health program, the master's program. And I just wanted to note a couple of our team members may not be able to chime in. We had a couple last minute emergencies come up, but I see myself and Ava are here, so hopefully we can answer the questions as much as we can. I in public health, and I also am trained in family medicine as well. I am seeing the rise of tuberculosis in Maine right now. So this is a very relevant topic to be discussing right now. I can't cite numbers of prevalence off the top of my head, but I do know that this is a growing issue, especially with among people experiencing homelessness and in shelters. And there, with the recent migration of new Mainers, there is a high prevalence of latent tuberculosis worldwide. And so with a lot of those shifting demographics, there's just a real need for screening and treatment. Obviously, this is active, so it's a bit of a different situation than latent tuberculosis, but I'm glad that we chose this topic, so it's very relevant to what's going on in the state right now. And Ava, I don't know if you have anything to add, but those are my 2 cents.
Hi everyone, my name's Ava. So I'm actually from Long Island, New York, and right outside the city, there isn't that many unhoused people, so I don't really know the prevalence over there, but over here, they're definitely in Saco and whatnot. There's definitely a large population of unhoused and whatnot, so I believe that it does affect a lot more people in this area of Maine than it does back at home for me. I'm not, like Emily said, I'm not sure of the numbers and whatnot, but it definitely seems to be a little bit more prevalent in this area rather than northern Maine or stuff like that.